You're listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is an academic medical oncologist at Dana-Farber Cancer Institute and instructor in medicine at Harvard Medical School. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series in colorectal cancer. Today, we're discussing liver-directed therapy for colorectal cancer with Dr. Ammar Sarwar. Dr. Sarwar is an associate professor of radiology at Harvard Medical School and an interventional radiologist at Beth Israel Deaconess Medical Center in Boston. He's also one of the clinical masters that many of us in the Boston community turn to for help in thinking about IR interventions, not just for his willingness to do these procedures for patients, but also his willingness to say no and give us a balanced perspective on the path forward. Dr. Sarwar, I always like to start these conversations with a brief intro into our guests. So can you tell me a bit of how you ended up as an interventional radiologist focused on cancer care?
First of all, I'd like to thank you for inviting me to speak on this podcast, certainly a topic that I'm very passionate about. I trained in interventional radiology at a liver cancer center, which was also a liver transplant center. So we did a high volume of liver-directed therapies, primarily for hepatocellular carcinoma. But as the field has evolved since I first started practice nearly 10 years ago, I have to say that I identify now more than an interventional radiologist as an interventional oncologist. And as we started to see kind of the benefits that some of our therapies, for example, ablation being a curative therapy, provided to our patients and started following patients longitudinally, we also developed synergies with our medical oncologists and our surgeons to try to get as many patients as we can to curative therapies. And I think that's the direction that I'd like to continue seeing this field move forward towards.
Yeah, I'm always happy to hear someone say curative therapy. That's the goal after all. So our main topic for today is liver-directed therapy for metastatic colorectal cancer beyond systemic therapy. And I think any discussion on this topic requires a bit of an anatomy refresher. So can you walk us through some of the hepatic anatomy and how that influences your perspective as an interventional radiologist and interventional oncologist, and highlight some of the features that are important for therapeutic interventions?
The way that I think about the liver is primarily as segments. The reason why I'm looking at it in segments is, first of all, where does the tumor lie? Is it close to central hilar structures, or is it farther away? Is it closer to the capsule? How many segments are involved? Because that often influences what is the potential of that patient to undergo surgery. And then finally, when I treat this patient, how selective can I be in treating this patient? Because I really believe the way forward for liver-directed therapies is to offer a hepatocyte sparing approach. So we want to maximize damage to the tumor, but minimize damage to the normal liver. And that's something that I think we can do with ablation, with chemoembolization, and with radioembolization as we offer more and more selective treatment. So really, when I'm thinking about the liver anatomy, step number one is, what are the segments that are involved? I think step number two is the hepatic arterial anatomy, especially when it comes to transarterial therapies. And the hepatic arterial anatomy is very interesting. We do about 5 to 6 hepatic arterial infusions of radioembolization or chemoembolizations every week. And still every week I'll see a type of anatomy that I haven't seen before. So nearly 30 to 40% of our patients will have variant anatomy. And that is what keeps us on our toes when we're doing these procedures.
For sure. Yeah, this is an important topic, right? If 80% of colorectal cancer patients have liver mets, this is a dominant problem for these patients. So let's talk about Y90 radioembolization. This has made a lot of advances in colorectal cancer, and we also have some contemporary prospective randomized trials, some modern trials. The SURF-LOX study published in the JCO by Guy Van Hazel in 2010, and the combined Foxfire trials in the Lancet by Dr. Hassan in 2017. So can you give us your thoughts on these data and how they influence your practice, both as the first-line trials, and then we'll talk about the second-line trials as well?
I think the first-line trials were really important data. As you know, and as most of our listeners know, the data showed that there was no benefit in overall survival or progression-free survival in first-line Y90 combined with systemic therapy compared to systemic therapy alone, but there was some benefit in hepatic progression-free survival. So the way that I interpret that is, number one, radioembolizations killed tumors inside the liver. However, the benefit wasn't sufficient to translate into a survival benefit. And there are several reasons for this. First of all, just broadly as a whole, medical device trials and interventional radiology trials have a very high failure rate for the first few trials. And there are several reasons for that. One is interventional radiologists typically have not been heavily involved in trial design. So as an example, when we look at the protocols for the Foxfire and Surflox trials, there's extremely detailed information on dosages for the systemic therapy drugs. How much are you giving per meter square? How do you individualize therapy for patients? But when we look at the Y90, the trial basically says Y90 was given, as if that's a black or white thing, a 0 or 1 Boolean flag. And it's not, because radioembolization, and we've certainly learned this since Surflox and Foxfire, radioembolization is less about the delivery of radiation and much more about dose. And we've made strides in the last 10 or 15 years in terms of dosimetry and maximizing dose to the tumor, minimizing dose to the normal liver. So as an example, most of the therapies that were provided in the Surflox and Foxfire trials were non-selective whole liver or lobar therapies, which were affecting not only the normal liver, but also because you're distributing the same amount of radiation over a large area, you're minimizing the radiation effect on tumors. And now in most recent years and in some of the newer trials, we start to find that if you offer more selective therapies and you maximize the dose of the tumor, the effect is better and you start to see more beneficial effect in outcomes like progression-free survival.
That's helpful. I mean, that's such an important lesson about trial design, about oncology in general. Like, good ideas don't make good trials and good oncology, and more is not better. Better is better. And this has come up a lot in this series. So now let's talk about second line data, because I think that's where we've seen some more positive results. The EPOC study in JCO by Mary Mulcahy in 2021. Give me your thoughts on this. And more broadly, where do you think we should be putting Y90 in the care of colorectal cancer patients?
Sure. So I think the EPOC study was a powerful step forward. And, as you said, it all depends on the trial design. It was performed by investigators who were experienced in radioembolization at centers that had been doing radioembolization for more than 10 years. I think that's really important because there's a learning curve to these transarterial and localized therapies that doesn't exist for most pharmaceuticals. So experienced investigators selecting the appropriate blood vessels to treat and providing a much higher dose of radiation than if you had done non-selective therapies. I think that's one key aspect. I think the second key aspect is that this was done in second line patients. And I think that's important because as you get towards the third line and the fourth line, the options in systemic therapy start to decline or become less appealing to patients and oncologists as well. I think the other thing to understand, and this again goes to a little bit of problems with doing these trials, is the trial period. So all of these trials were done over a period of 6 to 7 years. And despite the protocol being fixed at the beginning of the trial, during that time, clinical practice changed. So even the data for EPOC in 2023, and that EPOC came out in 2021, the data was collected from 2008 to, I believe, 2018 or so. And so the data is already old because practice has moved past what was done at that time. And this is a challenge that we often face in interventional trials. A great example of this is the stroke thrombectomy trials. The first few trials were negative. And then as the devices improved, as our ability to use the devices improved, as our selection improved, the trial started to turn positive, and now we have a great therapy. So I think EPOG is a great trial. It has certainly shown us the door in terms of how to design a trial, how to select the appropriate cohort, and how to make sure that the therapy is provided consistently between centers, especially as it relates to the techniques refinements for local regional therapy.
I think it's a really, really helpful point. And yeah, things have moved forward. We've also learned a lot about liver versus non-hepatic disease, which we talked about in an earlier episode, the role of immune therapy with Dr. Fakih. When you're seeing a patient with hepatic disease, they've received FOLFOX, maybe they're on FOLFIRI, where do you fit this in? Who is the right patient for this? How much extrahepatic disease is too much? What are the lab parameters we should be looking at?
If I see a patient who's been referred, let's say early in their disease state, if it's not first line, maybe second line or third line, I think the key differentiator for me is really the performance status. I think performance status is number 1, 2, and 3 And then in terms of hepatic arterial therapy, let's start with ablation actually. So I think if you have less than 3 tumors in the liver and they're located in segments that can be reached with an ablation needle, which for most segments of the liver, that's true, ablation will be my first choice. And the reason for that is obviously the data, both from hepatocellular carcinoma as well as colorectal cancer, that shows that this is extremely similar to surgical resection, but fewer complications, less morbidity, quicker recovery times. If for any reason, either the tumors are larger than 3 centimeters or they're multifocal, if a patient is not a candidate for ablation, then I'm looking at, could this patient, and again, we're talking about somebody with a normal performance status, good liver function, good renal function, no major comorbidities. Then the next step that I'm looking at is, can I potentially downstage this patient for surgical resection? Because one of the things that I really feel bad about, again, this has nothing to do with my field, is that not enough patients with metastatic colorectal cancer and liver-only disease are getting resection. And so the first thought that I have is, how can I help my surgical oncologist downstage this patient? And there's a variety of ways that I could do that. So for example, if there's bilobar disease, but the bulk of disease is, let's say, in the right lobe and there's a single tumor in the left, could I ablate the left lobe and have the patient get a hepatic resection? The second option is, well, if the patient has predominantly right lobe disease, but the future liver remnant is small, could I do techniques like portal vein embolization or hepatic venous deprivation in order to hypertrophy the future liver remnant and allow the surgical oncologist to do a curative resection? Because I think resection really helps patients. Now, let's say the patient is not a candidate for downstaging. Now, the patient has received 1 or 2 lines of systemic therapy, their performance status is good. Then the next thing I'm going to look at is their bilirubin. I think just as a rule of thumb, a bilirubin of less than 2, and I think this is true for most systemic therapies as well, a bilirubin of less than 2 gives me some confidence that I can treat this patient easily without causing any damage to the liver or risk of hepatic failure. And so then I'm starting to look at my hepatic arterial options. I think Y90 radioembolization is more likely to cause tumor necrosis, but is also needs to be delivered safely in a hepatocyte sparing approach. If that's not an option, let's say the bilirubin's a little bit higher than 2, then I start looking at chemoembolization. And drug-eluting beads loaded with irinotecan have certainly shown benefit in randomized trials, both in terms of survival and progression-free survival, although that data is old at this point.
Excellent. And what's the recovery time for patients undergoing these procedures, undergoing radioembolization, chemoembolization, and ablation? How much is outpatient? How much is inpatient, especially as we think about resources?
Radioembolization has always been outpatient. It's 2 procedures, a planning procedure, which is just a diagnostic angiogram, and then a treatment procedure. Both of these are outpatient procedures 100% of the time. Chemoembolization, almost 10 to 15 years ago, used to be a post-procedural admit for a day. But actually now, with the use of steroid regimens to ward off post-embolization syndrome and good pain medications to help with the right upper quadrant pain that can happen for some patients, all of our patients who underwent chemoembolizations in the last 3 years were done as outpatients. We actually looked at readmission rates and early admit rates, and it's less than 10% of patients who will need admission or readmission because of pain control or other things. So in general, these therapies are really well tolerated. There is data, randomized data actually, that supports the use of a single dose of intravenous steroids at the time of the procedure. And that helps with the post-embolization syndrome, which is mostly related to liver inflammation more than anything else. The textbook says that for example, after radioembolization or after chemoembolization, that most patients will have post-embolization syndrome for up to a week. And the range is 30 to 80% of patients. Post-embolization syndrome occurs because of cytokine release when tumor necrosis happens and is indicated by a flu-like syndrome, right upper quadrant pain, low-grade fevers, loss of appetite, and some fatigue. The textbook says 7 days. Most of my patients, because we're treating them in a selective fashion, will have it for 1 or 2 days, and then they're back to doing their activities of daily living.
Excellent. And so you talked about these interventions as a technique to downstage patients for the purpose of surgery. And that's, I think, a fantastic point. That also brings us to one of the really interesting interventions that's been pursued in colorectal cancer, really going back to the 1970s. And that's placement of hepatic artery infusion pumps for the purpose of giving FUDR. So as opposed to the percutaneous approaches and the intravascular approaches, this is a surgical approach. So certainly would involve admissions. And And I want to talk about this. Generally speaking, I wanted to focus on things where we have the most mature and modern data with prospective randomized trials that are broadly available for patients and for providers at many centers. And FUDR via hepatic artery infusion pumps is a little different because it's done at specialized centers. As a reminder for our listeners, FUDR is a fluoropyrimidine like 5-FU, and it's subject to first pass metabolism. So when patients receive it, it's quickly cleared by the liver. And the idea is that if you can infuse this into the hepatic artery, you can achieve high concentrations in the tumor and then quickly clear it in the liver with a reduced systemic exposure to FUDR. And this led to tremendous interest in the 1970s and 80s to placing hepatic artery infusion pumps and delivering FUDR. A lot of work was done to optimize how to give this in doses. And compared to, I would call it, maybe oncologically ancient approaches to chemotherapy, older fluoropyrimidine regimens, this seemed to be a promising regimen that improved resectability with response rates probably around 40%. When we compare that to more modern regimens as FOLFOXIRI or even FOLFOX, it's probably not as impressive, although prospective data really is lacking compared to modern regimens. Nevertheless, this is widely used throughout the United States to downstage patients and as part of a surgical approach. And so I'd like to hear your thoughts on FUDR and hepatic infusion pumps. When should we reach for this? How do you think about this in the context of liver-directed therapy?
Sure. I think when we think about FUDR, and full disclosure, I don't do these procedures. I think we have to look at the different paths that surgically placed intrahepatic arterial pumps took compared to percutaneous transarterial therapies. Because the liver has been a challenging place for systemic therapy to reach, everybody's always been interested on how do you treat liver tumors more effectively. What we learned from animal studies soon after the early 70s and 80s when transarterial chemoembolization was introduced was that transarterial chemotherapy was not very effective, even though it was providing the chemotherapy directly to the tumor. The main reason for that, which I think is the main difference between TACE and hepatic arterial infusion with FUDR, is that even though you are infusing the liver with the chemotherapy, it doesn't stay there very long. It washes out over time. And this is one of the reasons why for FUDR, your infusion times are typically about 24 hours and 48 hours, and you have to keep giving those infusions every 2 weeks for several cycles. Whereas with chemoembolization and with radioembolization, we give the therapy once. When we give that therapy once, we are combining it with an embolic agent. In the case of chemoembolization, it was originally Lipiodol. And now for colorectal metastases, we use drug-eluting beads. And these beads get stuck in the arterioles and they have the drug attached to them. And they basically diffuse the drug over the next several weeks. So you don't need to have a pump implanted in the patients. The same way with radioembolization, the radiation, it's a brachytherapy approach. The beads get lodged into the arterioles next to the tumor. They attack the tumor with radiation over the next several weeks until the half-life causes a decay and the radiation goes down to baseline. So I think that's the main reason why, first of all, when you combine the transarterial infusion of chemotherapy with embolization, you're able to give more drug directly to the tumor. There's less systemic seepage that happens, and there's animal studies that prove that, which improves the safety of the mechanism by which TACE occurs compared to hepatic arterial infusion, but also the efficacy. So I look forward to a time when these two therapies start to merge. And, we're always challenged by funding for these novel ideas, but I would love to see a therapy in which even if you placed a pump, if you're giving the hepatic arterial infusion, that you actually combine it with an embolic so that you can use a smaller dose of chemotherapy and it stays in the tumor longer. So I look forward to having some kind of TACE approach on the flip side with FUDR, because right now we're only using irinotecan when it comes to colorectal metastases.
That's a great thought I hadn't thought of before. As we think about trial design for FUDR, and I think one of the challenges is the lack of modern prospective data, because I don't think we can look at publications from 1989 or 1993 and say that this stands up to modern rigor. But at the same time, you hear reports of patients who've done very, very well. And of course, we hear reports of patients who haven't. But that'd be an interesting way to randomize patients, would be to receive standard FUDR plus or minus an embolization agent to try and improve penetration and reduce systemic exposure. And that would be, I think, appealing to the surgeons who are placing the pumps and feel committed to them, and the patients are committed to the idea of pursuing it. but also allow us to look at the risk-benefit ratio for patients. So I love that idea. Today, we've been hearing from Dr. Ammar Sarwar discussing liver-directed therapy for colorectal cancer. We had a refresher on hepatic anatomy, how we should think about segments, the arterial infusion of drugs into the liver, and how we can use embolic agents to slow down transfer of these drugs through the liver and improve anti-cancer effect as opposed to systemic effect and quick washout. We talked about Y90 radioembolization and how it really is a preferred agent in the later lines of therapy, and it doesn't really improve outcomes in the first line. Maybe that's a biological difference. Maybe that's just because we've gotten better at it. And so the later studies had better results. We talked about ablative techniques and using percutaneous needles to treat small metastases, which can have excellent outcomes, both as part of a surgical management and palliative management. And we also talked about FUDR and infusions via hepatic artery and some of the limitations of that, but also some potential innovations going forward. Thank you for joining us. This is Dr. Benjamin Schlechter for In Discussion.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.